This next position is the lateral position. So equipment that you might need is obviously your OR table, whatever lateral positioner that you're going to use. This is a bean bag. It is exactly what its name is. It's a bag full of beans. This will go down onto the bed. I did put a draw sheet under it so we can move it easily. You can pick this up, but I don't like to pick it up by the bean bags. I might tear it. I've got, you can also use a pegboard, which is a different type of lateral positioner that I don't have to show you right now. It's surgeon preference. You just have to ask your surgeon, other people at your facility, somebody will know. Also got an axillary roll, which is for anesthesia. It will go up under the arm. It doesn't actually go in the axilla. It goes maybe an inch or two below that. It goes under the patient. I'll show you where to place it. It helps the chest expand, prevents brachial plexus injury to the bottom shoulder. I've also got my foam, pillows, another draw sheet, and I'm gonna have plenty of people to help because this is a dangerous position to get in. The main risk is falling off the table because they're going to be on their side, which obviously you don't naturally want to be on your side. So a lot of times they'll shift forward or shift back. Just a safety disclaimer, I've seen every type of lateral positioner fail during surgery. I've seen this beanbag fail. It's got had a hole in it and an air leak. The air leaked out and the beanbag kind of went limp and fell apart. The patient shifted over. I've seen the pegboard fail where the pegs come loose and pop out and the patient shifts. That's why you want to make sure that you're securing them any way that you can to where if this main positioner fails, they're not going to fall off the table. So how this works is it has a little nozzle on it. What you'll do is you'll put, we have like little adapters that go in the end of this. You hook a suction tube, unsterile suction tube to this and have it running off to a suction device. Suction canisters, Neptune, whatever you use. Once the patient's on here in position and you kind of taco the patient up, you'll apply the suction and this beanbag will become rigid. It becomes very hard, so you need to make sure your patient's in the right position and that your beanbag is not folded to where it's going to create a hard ridge that's pushing against the patient's skin the whole case. Right? This next position we're going to talk about lateral. So they can be right or left lateral. Left lateral, which is what this patient is in, means that the left hip is on the bottom. If they're flipped over, they would be right lateral. Right hip on the bottom, left hip on top. Maybe opposite of what you think it should be. I've already talked about safety concerns about falling, having all your equipment ready, securing the patient. But we're going to move from head to toe and talk about the different areas. So first, you've got the head, which is controlled by anesthesia. Typically, they'll have a pillow or a foam headrest, something to keep the patient's head and spine in a neutral position. You've got the arms. I've got my bottom arm coming out straight out on an arm board. I've got it foam protecting it and supporting it. I put a safety strap over it to hold it on there. The upper arm, there's a few different things you can do. You can put a bunch of pillows in between the arms and secure it like that. We have what we call an airplane arm holder, which is an arm holder that connects to the bed. It comes up, goes over, or like that, and you can rest the arm on it. It holds the arm up like that. That's great for if you're doing elbow surgery. You can position it perpendicular where the elbow just hangs right over that airplane arm holder like that. There's also some different other types of positioners. There's a bone foam that goes in between it's got a tunnel for this bottom arm and it comes up and actually slants down so then the arm can rest like that too for shoulder surgery. That's surgeon preference. Next, we've got our axillary roll in place. So how we did that was anesthesia controls the head, somebody lifts the patient's body, another person puts it under here. Typically these are gel rolls. I didn't have one, so in a pinch you can use a saline bag wrapped in a blue towel. All right, so got that. The bean bag is going to support the main part of my body here. Coming down, I've got my safety strap over top of the leg, top of the, across the hip, across the chest, wherever you're operating, move it to a different area. You want at least one safety strap on the patient so if this bean bag deflates during surgery, they won't fall off the table. They may shift, but they won't actually fall off. Leg positioning, what I've got is the bottom leg is flexed. Bottom leg's flexed. It's supported with foam pads underneath. The top leg is straight and neutral. In between, I've got a pillow. I'm making sure my feet are not resting on the bed or touching anything, that they're floating and supported. What this does is when I have my bottom leg flexed, my top leg going straight, I almost create a base for my body that will help hold it up to some degree. It won't hold your body up all by itself. You'd still go over the top and go off the table, but it can help if you have other positioning devices and safety straps and different things like that on different parts of the patient. So what you do, you'd have at least 4 people doing this. You would take the bean bag and you taco the patient up in it like this. Pull it up, make sure it's in the right position. Someone would apply the suction to this nozzle, and this would get very rigid and hold the patient in this position. Then you can re-secure your safety strap wherever it needs to go. This is another one where considerations for Foleys and lines, and they need to be thought about beforehand, where they're going to come off. You've got a Foley in, you're putting it in before you flip the patient lateral. It's going to come off and go up to the head or the foot, depending on what you do at your facility. Another concern would be bovie pad placement. I wouldn't put my grounding pad on until I position the patient, so I know what the final position is going to be, and then I could slap it on their thigh, on the side of their thigh, or on their back, or somewhere like that, or if I had to, the upper arm, just where it's out of the way of the surgical site. And like I said, I want to wait because I don't want to position the patient and have my bovie pad in an area that's inaccessible throughout the case, and possibly got it, was wadded up during the move. This type of positioning is used a lot of times for hip surgery, hip replacements, acetabular fractures. It can be used for lower leg injuries if they need to get to the side, ankle. Any type, could be like a lung surgery or a kidney surgery. They need access to the side over here. Or it could be what I was talking about earlier, where it could be an arm surgery where they need the arm bent like that. So olecranon, an elbow, something like that.